So, hello everybody, this is Dr. Gurudev Swami, and I am working as Assistant Professor in the Department of Pathology, VKL Walawalkar Rural Medical College and Hospital. So, today I am going to take the topic adenocarcinoma of the colon. So, adenocarcinoma of the colon is also called as colorectal carcinoma, is the most common malignant tumor of the gastrointestinal tract. So, this is the tumor adenocarcinoma, which is present in the colon. Etiology and risk factors for development of this colorectal cancers, the factors that increases the risk and the factors that reduces the risk. So the factors that increases the risk are diet, hereditary syndromes, inflammatory bowel diseases like ulcerative colitis and Crohn's disease, and others like Streptococcus bovis bacteremia, increase in age, family history of colonic cancer in first degree relatives, prior colorectal cancer. And in the diet, animal fat, insulin resistance, fiber, deficiencies of vitamin A, C, and E, hereditary syndromes like polyposis coli, MYH-associated polyposis, non-polyposis syndrome, that is Lynch syndrome, and factors that reduces the risk are dietary factors like diets rich in cruciferous vegetables like cauliflower, Brussels sprouts, and cabbage, and vitamin A, and protective effect of aspirin and other NSAIDs. So here we can see the sequence of events due to ingestion of animal fat, which is involved in the risk of development of colorectal cancer. Ingestion of animal fat, non-vegetable fat, that is red meat and processed meats, due to increased ingestion, it causes increased proportion of anaerobes in the gut microflora, which increase hepatic synthesis of bile for that, and conversion of normal bile acids and cholesterol into carcinogens by anaerobes in the gut microflora. The microbes which are present in the gut microflora, they convert the normal bile acid and cholesterol into carcinogens by anaerobes, and that causes increased risk of colorectal cancers. There are various factors and syndromes like polyposis coli, familial polyposis of the colon, like this. So this is the case of familial adenomatous polyposis with numerous polyps in the colon. So all these are the polyps. Numerous polyps are present in the colon, and further they can be converted into neoplasm or the colorectal carcinoma. MYH-associated polyposis, hereditary polyposis, colorectal cancer, inflammatory bowel disease like ulcerative colitis and Crohn's disease can lead to adenocarcinoma of the colon and other factors. Then coming to the pathogenesis of this colorectal cancer develop from combination of multiple molecular alterations and mainly divided into genetic abnormalities and epigenetic abnormalities. Genetic abnormalities are those abnormalities which activate the oncogenes or which inactivate the tumor suppressor genes. So the genetic pathway, it consists of two pathways like classical adenoma carcinoma sequence and microsatellite instability pathway. These two are the genetic pathways. So we will see one by one. So adenoma carcinoma sequence, this is the uh, normal mucosal colorectal epithelium. This is the submucosa. This is the mucosa, and this is serosa. So this is the normal colon and normal epithelium. There are three phases in this cycle. First is in the sequence. First is initiation. Second is expansion, and third is invasion. So in case of initiation, there is adenoma, early adenoma, and it is called as first hit. So in this, there is mutation of tumor suppressor gene, that is APC. Because of APC inactivation or beta catenin activation, there is formation of adenoma. Then this, in case of intermediate adenoma, that is second hit under expansion phase, there is proto-oncogene mutation, that is KRAS mutation occurs, and KRAS or BRAF activation. Here is the intermediate adenoma. This is the late adenoma in the phase of expansion where mutation of other tumor suppressor genes like TP53, SMADs occur, and SMAD4 or TGF-B beta 2 inactivation, TP53 inactivation occurs in this late adenoma. And in the phase of invasion, there is fully grown carcinoma is there, and there is activation of telomerase, and this leads to metastasis. So this is the adenoma carcinoma sequence. Uh, the pathogenesis of development of colorectal cancers. So what happens? This is the epithelial cell. On the cell, there are WNT receptors are present, and this is the beta catenin. This is the APC. What happens? The two cells, they are connected with each other with E-cadherin. When WNT attaches with WNT receptors, it causes this beta catenin combination with APC, and that causes degradation of this beta catenin. But in case of cellular proliferation, what happens? The beta catenin does not connect with this APC, and this beta catenin goes into the nucleus and it connects with the TCF, and that causes cellular proliferation. In another case, there is mutation of APC. This mutation of APC causes beta catenin to go into the nucleus and attach with the nucleus TCF, and it causes cellular proliferation. So this is the mechanism of cellular proliferation present in the case of adenocarcinoma of the colon. Second pathway is the microsatellite instability pathway. It is also called as defective DNA repair. So this is the normal colon, normal histology. These are the mucosal epithelial cells. This is the submucosa. This is the muscularis propria, and this is the serosa. So what happens in the normal colon? There is mutation in the DNA mismatch repair genes, either inherited or acquired. So this leads to formation of adenoma, hypertrophy and hyperplasia of epithelial cells causing the adenoma, and there is microsatellite instability involving the promoter region or coding region of genes involved in the cell growth differentiation and or apoptosis. And this early adenoma, it is converted into fully grown carcinoma. There is accumulation of mutations in numerous genes that regulate cell growth differentiation and or apoptosis. So microsatellite instability pathway involving the genes like MSH2, MLH1. These two genes are DNA mismatch repair genes. And second, type 2 TGF beta receptors, which are required for cell proliferation, and pro-apoptotic gene like BAX, which helps in survival of abnormal clone of the cells, and BRAF, which is the oncogene. So this is the second pathway, that is microsatellite instability pathway, or it is also called as defective DNA repair. Then we will see the epigenetic abnormalities. So what happens here is the somatic cell, it is converted into the cancer cell by epigenetic abnormalities. Epigenetics is reversible, heritable alteration in gene expression which occurs without mutation. So this thing happens in the pathogenesis of colorectal carcinoma. So coming to the morphology, here we can see grossly, this is the tumor which is present in the colon. This is the tumor. So location, according to location, these tumors are classified, and colonic adenocarcinomas found in any location throughout the length of the colon, like in the right side of colon and left side of colon also. So here we can see this is the right side of colon, this is the left side of colon, this is the tumor present in the right side of colon, this is the polypoidal growth in the proximal colon. So when we see this is the tumor, so this is the polypoidal cauliflower-like growth in the lumen, like this. This is the polypoidal cauliflower growth in the lumen. Second location of this tumor is in the left side of the colon. So here it is the tumor in the left side of the colon, and this is the annular constriction happens in the lumen, and this is the tubular. So these two types are common in this left side of colon, annular and tubular. And this gives the napkin ring appearance or apple core constriction. So here like this. So this is the right side of colon. This is the polypoidal also proliferative growth. This is gross picture. This growth is present in the lumen. And in case of left side of colon, there is napkin ring appearance or apple core appearance. This is the gross picture of left-sided growth. And diffuse, these are the diffuse or tubular tumors. This is the gross picture showing diffuse or tubular tumor in case of adenocarcinoma of the colon. Then there are infiltrative and ulcerating tumors like this. This is the infiltrative growth and ulcerating growth, ulcerative type of carcinoma colon. This is the diagrammatic representation which we are seeing the infiltration and ulceration of the colon by the tumor. So coming to the microscopy of the adenocarcinoma of the colon, adeno means glands and colon, adenocarcinoma. So there is carcinoma of the epithelium, and the epithelium is of glands like this. So this is the muscular layer. These all are the glands, and these glands, they are lined by malignant epithelial cells. And what they do, they infiltrate this muscle layer. These are all are the neoplastic glands. Like this is the H&E section showing this is the muscle layer, and these are the glands which are lined by malignant neoplastic tumors, and they infiltrate this muscle layer, muscular layer infiltration by the malignant tumor. So here we can see this is one gland and it is lined by malignant epithelial cells, and in the center or the lumen of this gland there is dirty necrosis, and the nuclei of each cell, they have prominent nucleoli inside them. There is abundant mitosis also present, and there is nuclear pleomorphism. So this is the cut section, this is the H&E section showing this is the normal mucosa, and this is the tumor which is infiltrating. So here we can see this is the normal layer of the colon, consists of epithelial cells lining the glands. This is the mucosa, this is the submucosa, this is the muscularis propria, and this is the serosa. So here we can see the growth starting from the epithelial cell lining, and it is invading in the muscularis propria and submucosa. This is the tumor. So here, according to differentiation, these adenocarcinoma tumors, they are classified as well differentiated adenocarcinoma, moderately differentiated adenocarcinoma, poorly differentiated adenocarcinoma, and undifferentiated adenocarcinoma. So differentiation means how much the tumor looks in similar with the original tissue. So here you can see there are more than 95% glands, so it is well differentiated adenocarcinoma, and these glands, they are lined by neoplastic malignant cells. In this case, 50 to 95% glands you can see, so it is moderately differentiated adenocarcinoma. Here in this case, less than 50% of glands they are seen, so it is called as poorly differentiated, and in this case, no glands are seen, so it is called as undifferentiated because we can't differentiate it. So here also this is the normal healthy cells forming the glands. Here well differentiated, few of the glands they are lined by malignant epithelial cells. In this case, moderately differentiated. This is the poorly differentiated, and this is undifferentiated because there are no glands direct. So this is the normal gland lined by epithelial cell, mucosal epithelial cell. These are the well differentiated adenocarcinoma. This is the moderately differentiated adenocarcinoma, and this is the poorly differentiated adenocarcinoma. Here you don't see any gland formation. The invasive component of this tumor also shows stromal desmoplasia. It is one of the feature of this adenocarcinoma. So it causes firm consistency. So all these are the nests and islands of the tumor cells, and in between them, this is the stroma showing desmoplasia. Another subtype of this adenocarcinoma, the cells of this gland, they secrete the mucin. So here, these are the malignant glands, and they secrete this mucin. All this is the mucin. This is the gland, malignant gland. This is also malignant gland, and this is the mucin. So these tumors, the cells in these tumors, they secrete the mucin. So it is called as mucinous adenocarcinoma. So like this, these are the nests or solid masses of the tumor, and all this is mucin. So this is the special stain which is done for mucin. This is PAS positive. This PAS periodic acid chip stain, it gives magenta pink color like this. Coming to the another type of this adenocarcinoma, that is signet ring carcinoma. So name itself suggests there are signet ring in this carcinoma. So here you can see all these are the tumor cells, and these tumor cells, they are called as signet ring cell because they have the vacuolated cytoplasm, and which pushes the nucleus to the periphery, and it looks like the signet ring, so it is called as signet ring cell. This is the vacuolated cytoplasm vacuole, and this is the nucleus at the periphery of the cell, and it looks like signet ring, so it is called as signet ring cell, and the adenocarcinoma is called as signet ring cell adenocarcinoma. But coming to the clinical features of this adenocarcinoma colon, the tumors in the cecum, that is in the right side of the colon, they present with the fatigue and weakness due to iron deficiency anemia. So the iron deficiency anemia in older man or post-menopausal woman should be considered due to gastrointestinal cancer until and otherwise proved. In case of left-sided cancers, they produce occult bleeding, altered bowel habits or pain, and discomfort in the left lower quadrant. So there are various methods for investigation of this colon carcinoma. First one is the occult blood loss in the stool. which is done by Guyak test. Second, the tumor markers. There are elevated levels of carcinoembryonic antigen CEA and CA 19.9. We can do flexible sigmoidoscopy. We can do colonoscopy to help in the direct visualization of the cancer and may be used to take the biopsy. So that's why it is the investigation of choice. So colonoscopy, in case of adenocarcinoma colon, it is investigation of choice. In case of radiology, the radiological test which we can do are. So this is the fecal occult blood test. This is the sigmoidoscopy. This is the colonoscopy. So in case of radiology, we can do double contrast barium enema. It is the radiological investigation of choice. When colonoscopy is contraindicated in the patient, so we can do double contrast barium enema, and it is the radiological investigation of choice, and it shows apple core appearance on double contrast barium enema. We can do ultrasonography for screening of investigation of liver metastasis. So this adenocarcinoma is most commonly metastasized to the liver. So in that case, we can perform ultrasonography. We can do spiral CT also in the elderly patients. So this is the barium enema, and this is showing the apple core appearance or napkin ring appearance. This is called as apple core appearance or napkin ring appearance, which is seen on double contrast barium enema. We coming to the staging and prognosis of this adenocarcinoma colon. There are two most important prognostic factors, that is depth of invasion and presence or absence of lymph node metastasis. Invasion into muscularis propria reduces the survival rate, which is reduced further in presence of lymph node metastasis. Poorly differentiated and mucinous carcinomas, they are associated with poor prognosis. So there are various methods like Dukes and Kirkland, Asler and Collar staging methods were being used, but presently they are replaced by TNM staging, that is tumor nodes and metastasis classification and staging system from AJCC, that is American Joint Committee on Cancer. So here you can see this is the mucosa, this is the submucosa, and this is the serosa. So what happens if tumor is present only in the mucosal lining, then the stage is T1. If it infiltrates the submucosa, then it is T2, and if it invades the muscularis propria, then it is T3, and if the tumor is invading the serosal layer, then it is the T4 stage. So these are the lymph nodes involved in case of adenocarcinoma. N0 means no suspicious lymph nodes, and N1A, N1B, N1C, N2A, and N2B, all these are the involvement of the lymph nodes in the vicinity of adenocarcinoma of the colon. So this is the AJCC, 8 AJCC stages, American Joint Committee on Cancer, which is combined with TNM stages. So there are 1, 2, 2A, 2B, 3A, 3B, 3C, and 4. All these are AJCC stages according to the TNM staging. Now coming to the spread of this adenocarcinoma, there are various methods of spread. First is the direct spread. Tumor can spread in the transverse, longitudinal, or radial direction. Second is the transverse spread circumferentially around the intestinal wall, which causes intestinal obstruction. Longitudinal spread along both the direction, and radial spread directly into the submucosa or muscularis propria, and then out into the serosa, pericolic fat, lymphatics, and veins in the mesentery, alongside bowel wall, and sometimes into the peritoneal cavity. Then the lymphatic spread is very much common. Tumor spread through the lymphatics into the regional lymph nodes, and the lymph nodes draining colon are grouped as N1, N2, N3. N1 means nodes in the immediate vicinity of the bowel wall. N2 are the nodes arranged along the ileocolic, right colic, mid colic, left colic, and sigmoid arteries. N3 is the lymph nodes in the apical nodes around the superior and inferior mesenteric vessels. So coming to the blood spread, there is venous invasion, which gives rise to blood-borne metastasis in the liver through portal vein, and it also spreads to lungs and bones. Then the transcoelomic spread, rarely it can spread by dislodging the tumor cells from serosa of the bowel or via subperitoneal lymphatics to other structures within the peritoneal cavity. So this is the case, this is the liver, and this is cut section of the liver, and it shows the metastasis from adenocarcinoma colon. So these things, this is the metastasis from adenocarcinoma colon. This is also metastasis. This is metastasis. These are all are the mets which are seen in the liver. So thank you very much.